we will be talking about induction of labor with our expert, Dr. Amy Buben. Hello and welcome to the New School OBGYN podcast, a podcast in women's health but for everyone. Our goal is to promote good and reliable knowledge because the source of your information matters. My name is Eric Schmidt. I'm a board-certified OBGYN, and sitting next to me I have another board-certified OBGYN, Dr. Amy Buben. Welcome back.
Thank you.
Surprisingly similar to the last. But please consider downloading and following along. We are on all the major podcast hosts, and check us out on the YouTube. So, like we said, today we're talking about induction of labor, and I did promise to tell you why Dr. Buben is an expert in this field, and, well, she is, I guess I would explain it, in our profession called a laborist. She specializes in labor. There's a couple, if people don't know, being an OBGYN, you can kind of do multiple things. And Amy manages almost all the patients that come in to our labor and delivery when she's on call with us, and takes a lot of that burden off of us. And so she's the one often our patients will see when they are in labor. How else would you explain it? I'm probably explaining it very poorly.
No, I think that's absolutely true. So with an OBGYN, you have OB and GYN and clinic. I think those are kind of the three parts of it. And I manage the OB labor side.
Yeah. So you don't do the clinic, which is nice in a few ways. It frees you up in a few ways. And you still help us a lot with our GYN surgeries, but mainly you're helping us with our labor and delivery. And so that's why I have her here talking to all of you, is to give her expertise on all of this. And so, again, what we'll talk about today is induction of labor. And what is induction? How do we do it? Some common misconceptions and hot topic and FAQ about it. So, Amy, go ahead and get us started.
Yeah, so there's a couple different reasons that we recommend induction for patients. And it's always balancing that risk of the pregnancy versus the risk of prematurity with infants. So what I mean by that is, at what gestational age or how many weeks along are we going to recommend an induction? And there's a wide range of reasons why. So it can be anything from medical reasons, like chronic hypertension or blood pressure issues, to you've passed that 41-week mark, and we recommend it to AMA or advanced maternal age when you're over the age of 35, which is actually quite young, but nonetheless in our OB world is when we start talking about advanced maternal age. So all those things can be a reason, as well as electively wanting an induction. So patients that say, I am ready to be done being pregnant, I want to go into labor, I haven't gone into labor on my own yet, and so can you induce me?
Because I think there are some common thoughts that going through an induction may, increase your risks of things like C-section or, I think basically C-section or potential other risks. And so I think there is a more recent study which disproved some of that information.
Yeah, there was a trial in 2018 that was really changed how we viewed induction, and it showed that there was not an increased risk of perinatal mortality or severe perinatal morbidity, meaning not an increased risk to mom and baby, and no increased risk of C-section, most importantly, for low-risk inductions at 39 weeks. And so that's kind of where the new mindset of inducing patients at 39 weeks came into play. And the reason 39 weeks is chosen is that is the prime time to have a baby. Mm-hmm. So ideally, we would love for everyone to go into labor at 39 weeks on their own. And again, it's just balancing that risk to the pregnancy, to the baby, mm-hmm. and the risk of induction versus continuing pregnancy in the hopes that you'll go into labor on your own. So,
yeah, and it's full term. We say term starts at 37 weeks, and that's an early term, but 39 weeks is two weeks past that. And like you were alluding to before, like if we're going past the due date, that some risks can come up, mainly with that placenta getting old and having a difficult time, providing for baby. And so 39 weeks is kind of a nice little time.
Yeah. And so talking about how do we induce someone? So if you're coming in for an induction, what's the process?
Yeah. So, well, so we have a reason. We say, okay, we want the pregnancy to be induced or the labor to get started. We first want to figure out, well, how close are you to going into labor on your own? And so we do it by doing a cervical exam, which is a digital exam where we see if the cervix is not only starting to open, so that's one component, but is it starting to thin? And so cervix is like a tube, and so thinning would be like a shorter tube, going from 100% to 0%. That's how we say that. But also, is the baby's head coming down and down into the pelvis, and is the cervix which position? And that, when we're doing the exam and someone is far away from labor, the cervix is actually harder for us to reach, meaning it's more towards the back or posterior to baby's head, versus if someone is kind of really close to labor, it's a lot easier to reach, and so that's more of an anterior cervix. And we call it consistency of cervix. As cervix far away from labor, is more of a denser feel, and closer, definitely softer, and so that's how we explain that. And this is all components, and we can add that up and give a numerical value to get what's called the Bishop score. Now, that tells us that if the patient has a given Bishop score, if the number is, we have a threshold for both moms that haven't had babies before and moms that have. And if that number is lower, so for example, if somebody has had babies before, and you add up all these components and the number is less than 6, we will recommend what's called cervical ripening. And that's kind of actually one of my favorite words in our profession, is the word ripening. But that just means how close it is to being ready for labor. And so if somebody hasn't had or has had babies before, their number is 6, less than 6, we recommend some of the medications or interventions we'll explain later on. Or if somebody hasn't had a baby before, we make that threshold at 8. So if you're less than 8, we would do these other interventions that we'll talk about here in a second. And that was a really long way of explaining that. I apologize.
It's important, though. We do it every single time for an induction.
Yeah. So what is cervical ripening, or what, it's, we want that cervix to, again, be a little closer to what someone would be if they're coming in active labor. And we can do that in a few ways. There's medications, and there's more of what we call mechanical ways. And so mechanical ways would be with what's called a Foley catheter. There's other osmotic dilators too, but most commonly it's the Foley catheter. There's a couple different brand names of this, just like this, and this is a Foley catheter that goes in the bladder, like for other reasons, because it's a small flexible tube that we can place, and then the tip of that tube blows up into basically like a golf ball sized balloon. And so if we put this in during an exam, so I guess I'll just go over the procedure. So if somebody's coming into the hospital, they have a couple options. And if we choose this Foley balloon option, it's put in during a cervical exam. We are able to get this small or thin flexible tubing into, that sounds really like I'm a plumber.
Straw that goes into the uterus.
And so it goes up through the cervix, and the tip of it goes right by baby's head, and you blow up that balloon to about that golf ball sized balloon, and then what you do is tape that to the patient's leg if you're using this technique, and what that is going to do is put a little traction on it, so eventually it kind of tricks the cervix into thinking that that's baby's head pushing on it, and it'll start that process of cervix ripening, like we talked about before. There's another balloon that uses 2 balloons, one in by baby's head and one in the vagina, pushing on the cervix that way. Not my preference, but I know a lot of people do prefer that option. And so we talked about the procedure a little bit. And well, who is it good for? The nice thing about this, it's good for most people. The big downside is it's a little uncomfortable with the placement, and the initial cramping when it is placed is the most difficult part about it. There's always a small chance that with putting it in place, since you're kind of pushing on baby's head and the amniotic sac, that maybe the water bag breaks. But otherwise, it's really good. It doesn't have some of the potential complications that the medicines can have. And this is really the only option that we have in patients that have had a C-section before and they need to be induced. And so it's something that we use a lot, and potentially in combination with the medicines. And so, go ahead, Amy, with some of the medication options.
Yeah, so medications for cervical ripening, there's a couple different medications, but they're all prostaglandins that we use. So most commonly is something called misoprostol or Cytotec. It's a small pill that you can either place vaginally every 4 hours, or you can take by mouth every 4 hours. That's the protocol that we will usually use, is every 4 hours. Oftentimes, if people look it up, it's category X in pregnancy. And the reason it is because it causes contractions. And so in high doses, it can cause miscarriages or preterm labor. But it is very, very commonly used in all OB practices at small doses to get those contractions started. There's also something called dinoprostone or dinoprostone. I always call it Cervidil. It's also a prostaglandin. It's just a prostaglandin E2 versus the E1. It's a little flat, kind of looks like a sperm. That's what I always think it looks like. But it's a little flat medication with a tail. It's
like a mesh-like infused, I would say, insert.
Yep, and it's small. It's not something you're going to notice. It's significantly smaller than a tampon, but it's placed and it stays in for up to 12 hours. And it, again, is a prostaglandin that's going to help start contractions. There's also a gel that I haven't ever used. I've never seen it on formulary, but I'm aware that there's a prostaglandin gel.
I think they might use it in different countries more, like UK or something like that.
Prostaglandins, that being said, they are naturally made by your cervix. So when you're going into labor on your own, it's something that your cervix starts to make. And so this just kind of helps enhance that natural, it just gives more prostaglandins. Mm-hmm. The limitations to the medications are that once you give them, you can't take, especially the misoprostol or the pill, you can't take it away once you give it. And so it can create tachysystole, which is just too many contractions. And contractions are good to help the cervix change, but babies need that break in between contractions. And if you create too many contractions, it can create stress for baby or change fetal heart rate changes within the fetal heart rate monitoring. It also is not something that we use for C-sections because of the risk of rupture is increased to an unacceptable rate. I believe it's 6%. And then it can lead to GI upset or fevers. Usually this is going to be seen in the misoprostol or the Cytotec used at high doses, which we aren't using for induction, but it is known to potentially cause GI upset or fevers, which is kind of funny because Cytotec was a medication that was made originally for reflux, I believe. It's a GI medication at its baseline. Mm-hmm. But anyways, I've never used it for that purpose. Just a side note. Sorry. And then
I was trying to think of what to say, but I couldn't think of anything.
No, you're good. I was like, take that with a grain of salt. Yeah. Other options that we use for labor induction or augmentation, once you've progressed past that cervical ripening method, is oxytocin or Pitocin. So Pitocin is just the brand name of oxytocin. It is also something you naturally make in your body. You make it in your posterior pituitary gland, so up in your brain, and it creates contractions. It sometimes will be used during the cervical ripening in conjunction with a balloon, or it'll be used after cervical ripening as an induction method itself. And just on a total side note, it's the same thing you make after delivery to help stop bleeding, and breastfeeding is something that helps release Pitocin as well. So all those things
often known as like the happy hormone too, right? Like people say it's like the happy hormone.
Yeah, I've heard that. Yes.
In our world, it's this.
We do think it's a happy hormone because it causes contractions for us.
Happy.
Yes.
And so before we get to some of the other alternative options, I guess we'll kind of just go through like How do we normally do this? We talked about if someone's had a C-section, they don't get the medicines. It's just the balloon if they need to be induced. But, if we're using an example of a patient who is, first baby, 40 weeks pregnant, and, the cervix or Bishop score is like 1, meaning she's very far away from spontaneous labor. Usually we're kind of like, because the Foley balloon is a little uncomfortable to put in, often what we might do is start with like the medicine, get that to start softening the cervix and maybe opening a little bit. And if a few doses of that don't work, then sometimes we're using these things in combination and like using the balloon too. So it isn't always, just pick one and you're going to do that the whole time. You might potentially need both, especially if it's a first baby. Those inductions sometimes can be a little more lengthy. Would you agree? That's just kind of my own like practice in my field, but I think a lot of people do it that way.
Yeah, I would agree. I think I typically start with the medication.
Yeah. And, going through other potential alternatives to try to, induce somebody or improve their Bishop score. And you probably heard of this is the membrane stripping, or I say sweeping. And what that is done is, and this usually isn't done in the hospital. This is something that might be done in like your last week or two of the pregnancy, potentially, during an exam in office where, it's just a little more of an exam where the finger is placed between the cervix and baby's head, and you kind of just sweep around in a circle to try to release some natural prostaglandins and get the body started. And it might increase somebody's chances of labor in the next 48 hours or so. What I try to explain to patients too is like, if you have again, we're going to say Bishop score of like 1, 2, or 3 is probably isn't going to put you into labor. If your Bishop score is like 8, it might, or if you're really close to labor, it might kind of inch you there and put you over the edge into labor, but it's not a given. Some downsides to this, and I always warn patients about this, is it might cause some spotting. It's definitely a more uncomfortable exam, it might, yeah.
Very rarely I've seen people's water break during this
yeah.
as well. But, I guess if you're wanting to be induced,
you're not too mad
you will now get induced.
Yeah. Yeah. And, we generally don't you might see out there, can you break someone's water to induce them? And no, we don't want to do that. We want to start the process in these other ways to get them closer, because once you break the water, there is a start to increase that chance of potential infection. If someone has a long way to go, you might increase that infection risk. Nipple stimulation is also a way to create some contractions. And people often notice this too, like after they deliver and they start their breastfeeding, it causes a lot of cramping sometimes, but that releases naturally oxytocin, the medicine that makes you contract. And so that can be done, although it's not necessarily recommended to do that at home. But if someone absolutely does not want to use the medication, you could try this option technically, but it's less predictable.
Yeah, and I've actually used it in the hospital occasionally when patients would prefer not to start an induction with any of the medications. Mm-hmm. You can use a breast pump for about 20 minutes, and might not be the most comfortable thing, but you can certainly try that. And if you get milk during that process, you can save that as well. Mm-hmm. And so there can definitely be some benefits to it.
Yeah. Another big question too, and this is probably very dependent on where you are and what the current practices are and where you are, but can you do some of these options out of the hospital, or do they have to be in the hospital? Because it definitely would be not, the less time in the hospital labor delivery unit and the more time in the comfort of your own home is better. And they're trying to, there are studies coming out proving the safety of doing this as an outpatient, especially the balloon as an option. I don't know if anywhere would recommend, have a protocol for the medication outpatient. Do you know of anywhere?
I don't know of anyone that has the medication, but definitely the balloon has been been outpatient.
Where you can put it in the clinic and then, it falls out at home, or you come in the next day and have it taken out and then have your induction scheduled, is the way that would work.
Yep, absolutely. I've definitely seen that happen. And then typically at that point when you come in, you would start on Pitocin versus necessarily going the medication route if the balloon has fallen out on its own.
Okay.
And then just speaking of options at home, so a lot of people will ask questions about what I can do before I come in for an induction to try to get things going. And I've typically told people walking, none of these will necessarily get labor going, but could potentially be helpful, is walking.
Yeah.
Again, I know you talked about that nipple stimulation, whether that's outpatient or inpatient can vary. Raspberry leaf tea is something people will talk about. Not raspberry tea. It's the boring, bland sister of raspberry tea. So just raspberry leaf tea, not that tasty. Evening primrose tablets. You can get them over the counter. And then people have often asked me about castor oil, and I personally find this just creates a lot of diarrhea and no contractions. So not one that I usually recommend, but to each their own. Options of things that I've heard. I don't know if you've heard any other.
I've heard Chrissy say put it in eggs.
Like a raw egg?
Well, like a scrambled eggs or something.
Oh,
I don't know.
I think there's a lot of things you can try. But anyway.
Yeah, and so the more contractions beforehand, hopefully the closer someone can be, and so the induction is less of a process. But again, it can be a long process. How
long does it normally take?
First pregnancy, and let's say if someone has high blood pressure or preeclampsia, so they're potentially being induced at 37 weeks, it could take this whole process. Maybe 24 hours of just this before you even really get to the other process of the active labor. And so it might be a day or two potentially before baby's born, but you're always waiting, and that sounds terrible, but you're always weighing that against the medical condition and the risk of that too, and the concern for baby. But on the other side of things, like sometimes it does happen a lot quicker than that. That's like the worst case scenario, 1 to 2 days of this before your baby being born. But often if I have a patient that's had vaginal deliveries before and they have to be induced, whatever the reason is, there's, the cervix generally changes a lot quicker. And so if a patient comes in that morning, often they're delivering by later that day.
Yeah, absolutely. Especially if they're a multip and they're a little bit dilated. I find that the amniotomy that we touched upon after another induction method can often move things along really quickly. But again, it just really varies. So there's a lot of variables to it as to how long it'll take. And that's why we have multiple different medications and options to help with the process. Yeah.
So all in all, induction's not as scary as it may seem or someone may have heard out there. But we don't do it without due cause. And try to be as low intervention as possible, but also if we're inducing somebody, there's a reason. And so we want to kind of keep things moving forward. But anything else you want to add to this one?
No, I think you did a very comprehensive job, Dr. Schmidt. And as always, our goal is a healthy mom, healthy baby, and a vaginal delivery if it's possible.
All right. Well, good. Thank you, everyone, for listening again. And if you have any questions or comments, please let us know. And the content of the podcast and video are for educational purposes only, and none of the content meant for personal medical advice. Please contact your medical provider if you're in need for that. Thank you, everyone, for listening again. Have a good day. Thank you very much, Amy.
Thank you.